Dear audience, let me present the title of my PhD thesis, which is Diabetes mellitus and its effect on oral complications. My name is Bulcsú Bencze. I'm a second-year prosthodontic resident and a first-year PhD student in the Translational medicine program. My supervisor is Daniel Vég, my SMS is Bulcsú, and our statisticians are Bencze and Gergely Agúcs. My vision is to provide adequate dental treatment for medically compromised patients, focusing particularly on prevention and prosthetic rehabilitation. In order to achieve this, I would like to find and provide scientific evidence in the possible correlations between diabetes mellitus and oral complications. I have currently two ongoing topics. I have started both of them last year in September and in December. The title of my first project is about investigating the effects of different HbA1c levels on the severity of dental implant complications. As we all know, diabetes mellitus is a worldwide disease with more than 400 million people suffering from it. Patients with the disease tend to lose twice the amount of teeth compared to systematically healthy individuals. Moreover, patients with chronic hyperglycemia have an increase in the formation of glycated end products. These products can interact with their receptors, which are called RAGEs, and they release pro-inflammatory cytokines, the likes of interleukin-1 beta and TNF-alpha. All of these can be found in the periodontal tissue, which means that diabetes mellitus can increase periodontal inflammation, which could lead to alveolar bone loss, both around natural teeth and around dental implants as well. We can measure a patient's last 2 to 3 months of average blood glucose level with the help of HbA1c. Our aim is to find an HbA1c level adequate to provide safe dental implantation without long-term complications. To answer our clinical question, we have used the PFO format. Our population consists of patients undergoing dental implantation. The prognostic factor is diabetes mellitus, and our outcomes are marginal bone loss, pocket depth, bleeding on probing, plaque index, and implant survival. And we would like to use different HbA1c levels as a covariate for meta-regression. I have conducted the systematic search on the 13th of November in the 3 main databases with the following search key, which consists of 2 different domains. The first domain is for the population, and the second one is for the prognostic factor. After the search, we have identified more than 2,200 articles. After conducting the duplication removal, title and abstract selection, full text screening, and citation chasing, we have received 35 eligible observational studies. We have conducted the risk of bias assessment with the help of quality and prognostic studies tool. The majority of the studies have received low to moderate risk of bias, while 5 studies received high risk of bias, and therefore they will exclude it from any further analysis because of poor quality. Now I would like to introduce the results of our main outcome, which is crestal bone loss. Crestal bone loss is one of the hardest outcomes to measure dental implant success. It is calculated from a standard periapical X-ray made by the parallel technique between 2 different points. The first point is the implant abutment junction, and the second point is the uppermost point of the alveolar crest in contact with the dental implant. We have 27 articles in this analysis. The effect sizes are mean differences with 95% confidence intervals, and the outcomes are in millimeters. The heterogeneity in our analysis is very high. They are above 95%. The reason behind this could be because we have pulled together many different follow-up times, ranging from 1 year up to 11 years. We have different types of dental implants, restorations, and the oral hygiene indexes are different in each patient groups as well. We have 3 different subgroups for this analysis. 2 goes for patients with different control for their diabetes mellitus. Well-controlled patients are below 8% HbA1c, poorly controlled patients are above 8% HbA1c, and patients diagnosed with prediabetes have been grouped separately. The overall outcome for analysis is 1.90 millimeters. This is both statistically significant and clinically relevant as well. This number goes down to an almost insignificant 0.90 millimeters if we only consider patients with a well-controlled diabetes mellitus, and up to more than 2 millimeters for patients with poor control. To put this number into context, the baseline alveolar bone loss around dental implants is around 0.2 millimeters after the first year of the dental implantation and for every single year afterwards. This means that on average, patients with diabetes mellitus have a relatively 5-year older dental implant compared to the systematically healthy individuals. Of course, we cannot generalize this number for the whole diabetes population because we can see from the outcome that it is heavily influenced by the patient's glycemic control. In this slide, I would like to present the results of our meta-regression. We have used the patient group's average HbA1c levels as a covariate against the outcome, which is crestal bone loss. 21% of the mean differences can be explained by the different HbA1c levels, so we can say that there is some dose-response relationship between the two values. The strength of our analysis is that we could include high number of up-to-date studies. We had strict exclusion criteria to reduce confounding, and we have adhered to our predefined protocol as well. Unfortunately, we couldn't reduce the high heterogeneity, so it is one of our limitations, and there were no population matching for their oral hygiene in either of the studies. As a conclusion, we can say that patients with a worse than 8% HbA1c level have significantly worse clinical outcomes compared to the systematically healthy individuals and even to well-controlled patients. The implications for practice is that preoperative HbA1c measurements are highly advised. If the patient has poor control, then consultation with their diabetologist is necessary in order to normalize their HbA1c levels, and at least biannual dental prophylaxis for patients with diabetes mellitus. The implication for research is that more rigorous HbA1c measurements are necessary between follow-up periods to investigate the high HbA1c levels with other risk factors such as hyperlipidemia and obesity, and to investigate the normalization of HbA1c levels on the clinical outcomes for their dental implants. Currently, I am writing the results section of the manuscript. I would like to finish with this project by the end of May and start the submission. My second project is about the investigation of the effect of diabetes mellitus on the survival rate of oral squamous cell carcinoma. Head and neck cancers are widely spread malignant diseases all across Europe, with Hungary being on the #1 place in terms of incidence rate per 100,000 capita, with more than 23 cases. This translates to 3,000 new cases in every single year. I have chosen OSCC because it represents up to 90% of all head and neck cancers. Not only these type of diseases are very common, but they are dangerous as well. They are the 11th most deadly cancer type in Europe. In order to reduce the morbidity and mortality of this disease, early detection and prevention is key, and dentists could play a huge part in this. Up-to-date information says that patients living with diabetes mellitus have a higher chance to develop such malignant diseases, so our aim is to investigate the possible associations of diabetes mellitus and OSCC in order to help in the prevention and survival of the disease. In order to answer our clinical question, we yet again have used the PFO format. The population are patients diagnosed with OSCC. The prognostic factor is diabetes mellitus, and the outcome is disease-specific or overall survival. We have conducted the systematic search on the 5th of March in the 3 main databases. We have used a similar search key like before with 2 main domains, the first for the population and the second for the prognostic factor. As a summary, I would like to finish with my first project by the end of May and with my second project by the end of September. I would like to thank your kind attention with a quote from Friedrich Nietzsche: "Truth tends to reveal its highest wisdom in the guise of simplicity." Thank you.
Thank you for the nice presentation, and the floor is open for questions.
What is the actual clinical practice if a diabetic patient comes to the clinic before implantation? What do you ask? What do you measure before the implantation?
So dental implantation is usually, diabetes mellitus is usually considered as a risk factor for the dental implantation, but there is no real measurements for their glycemic control. So they are just discouraged from the dental implantation because it is a risk factor, but I hope that with the results of this study, we can encourage patients with diabetes mellitus to receive dental implants, because if they have a well-controlled glycemic value, then basically there is no real difference between the complication rate compared to the healthy individuals.
And is there a dental screening program for this vulnerable patient population?
Yes, in the prosthodontic clinic we have a work group for patients living with diabetes mellitus. We are doing screening and prosthetic rehabilitation and every other thing like that.
Thank you.
Thank you.
If I have seen well, you presented that the pre-diabetics were in a worse case than the well-controlled diabetics.
Yes.
Is it due to the oral hygiene, or is there something else you?
Partially it is due to the oral hygiene, but patients who develop prediabetes have other comorbidities as well. For example, obesity, hyperlipidemia, and they have bad diet as well. So all of these could introduce much worse clinical outcomes. So patients with prediabetes are very similar to patients with poorly controlled diabetes mellitus, but the patients with poor control have much more higher glycemic values. So that's why they have even worse clinical outcomes compared to patients with prediabetes.
Okay. Thank you. Any other questions?
Sorry, this is going to come together very nicely. Can we go back to your first forest plot? I mean, you really had such a nice arrangement of data and then a good number. So actually many times I just ask the stereotype question that the old-timers are different from the others. But here, as we look at this, that this seems to be something systematic. Since step by step, actually, I mean that you set it up in this way. But is there any good reason, which may be not just a simple bias, but something else, that in some studies actually there is no difference, and in some other studies there are bigger difference. And this seems like just a continuous kind of increase. So
Yes.
Is there any reasonable explanation for this?
I think there is. Usually when patients have much worse outcomes in the analysis is because, for example, the longer follow-up times. So, for example, if a patient has 7 years of follow-up times, their metabolic disease have more time to introduce more inflammation around the dental implants. So, for example, if there is a very little difference, it is usually due to the fact that that study has only 1 year of follow-up time. So that could be one thing. The other thing is that, of course, the different studies has different population with different oral hygiene indexes. That could be one case as well. And one more thing is that, for example, the last study in the prediabetes section has only cement-retained crowns. And cement retention can introduce much more severe inflammation around the implant than, for example, screw retention.
There is only a few seconds left, so I have only a comment. Since you have plenty of data, I definitely recommend to form subgroups, because the follow-up time, whether the patient was a periodontitis patient before, it's well known about 7-8 years the previous former periodontitis patients used to be peri-implantitis patients. And there are so many cofactors. Cementation, yes, if you carry out the cementation in a wrong way, and so on and so on. So I think there are too many bias in this study, and you have to be very careful to exclude all of those. And could be a possibility to form subgroups dealing with the former systematic diseases or oral diseases, right? Periodontitis, cementation, whether screw retained, and so on. So I think it's pretty hard to compare those studies to each other.
Yes, exactly. Thank you for your comment. And we are actually working on the further subgroupization of our results with the follow-up
Good for
times.
you. You already have all the articles.
Yes.
Thank you very much. The time is over.
Thank you very much.